Now I have the pleasure to present our second speaker, Dr. Kash, Yellepedi, who is an associate professor in the Division of Clinical Pharmacology, Department of Pediatrics, and Adjunct Faculty with Department of Molecular Pharmaceutics, College of Pharmacy, University of Utah. He received his pharmacy degree from Kakatiya University in India and PhD from Texas A&M University. The mic is yours. Pointer to use. Okay. No worries. That's fine.
Right, good morning, everyone. First of all, I'd like to thank Indiana CTSI and Dr. Sarah Quinney for providing me this opportunity to present some of my research that I've been working past couple of years. So for today's presentation, I would start with discussing about the disease state that I'm working on, which is sialorrhea. In other words, it is excessive salivation in children with neurodevelopmental disorders that include cerebral palsy, DMD, and maybe because of strokes related to trauma. It covers the entire gamut of neurological disorders in children. And then I'll talk about the problems with current treatment approaches. What are the drawbacks of current treatment approaches? And then I'll give a brief introduction about the off-label treatment of this disease with atropine eye drops, which is very commonly performed all over the world, in fact, in different physical medicine and rehabilitation centers. And then I'll talk about the drug formulation that we are trying to develop to address this disease, as well as to overcome the drawbacks of off-label use, which is mucoadhesive gel of atropine. I'll talk about the phase 1 study that we performed in healthy adults. And then I'll talk about how we use the phase 1 study to extrapolate that data to more of a pediatric PK using PBPK modeling approach. And then I'll end up with some conclusions, what we understood so far, and then where this study is going. So sialorrhea, or excessive drooling, excessive salivation, it's a huge burden in children with neurodevelopmental disorders. It's a chronic disease, and one of the major issues with this problem is it leads to respiratory illnesses, which is one of the leading cause of death in cerebral palsy patients. In fact, according to one statistic, a cerebral palsy patient with respiratory illness has 14 times more risk of death when compared with a normal counterpart. So it's a very chronic and serious problem which needs to be addressed. So especially with respect to the number of children getting affected by this disorder, 60% of children with neurodevelopmental disorders are diagnosed with excessive salivation or sialorrhea. So it's a major disease state that needs attention. In addition to respiratory illnesses, sialorrhea also reduces the quality of life of these children, especially when it comes to posterior salivation, where there is a lot of skin excoriation, and these children have a lot of social embarrassment. They don't tend to be more more social, and they tend to isolate themselves. This is reduces the patient's quality of life. Not only patient's quality of life, there have been reports that it will affect caregivers' quality of life too. So medical concerns, again, because of posterior pooling of the saliva, aspiration pneumonia, that's a big problem in these patients, progressive lung disease leading to more infections and other respiratory complications, and psychosocial concerns, isolation and low self-esteem. So just before I move more further into my talk, I just want to give a brief primer on salivary glands and salivation in general. So we usually have three major salivary glands: parotid gland, submandibular gland, and sublingual gland. These are the three major glands. In addition to that, we also have several minor salivary glands, hundreds of them, interspersed all over the oral cavity, behind, under the lip, and the soft palate, hard palate, under the tongue, and stuff like that. So the the saliva is produced by all these glands. So I'll just discuss about the current management options. So this is the guidelines by American Academy of Cerebral Palsy and Developmental Medicine Care Pathways. I know that's a mouthful. AACPDM. So this is the organization responsible for advising care guidelines for various cerebral palsy treatments. And according to them, the management of sialorrhea, mainly the first is the most least invasive management, which is behavioral or non-medical interventions. Motor intervention, they make the patient do some kind of exercises, and behavioral intervention, oral appliances. There are some kind of equipment or some kind of devices that they can use to pool the saliva. It will come back and you will empty it and put it back. And then in the middle, there is pharmacological intervention, and these include anticholinergic medications, your glycopyrrolate, scopolamine, atropine, benztropine, and then botulinum toxin. This is very widely used as well, where you inject this botulinum toxin into the glands, and kind of you're paralyzing the gland in a way that it won't produce saliva, and kind of you're shutting down, and that's how it works. And then there are more invasive procedures that involve surgical management, where you ligate the ducts of the glands that flow saliva into the oral cavity. These are more invasive. And then for some patients, you remove the glands altogether. Remove the submandibular gland, remove the parotid gland. These are some of the more invasive methods. So there is no one treatment approach. Usually it involves a combination of all these three approaches. From a less invasive, it's a kind of like a team approach. However, what I would like to point out here is, of all the inventions, according to AACPDM, anticholinergic medication is kind of the only one that has shown consistently that this helps. So coming to anticholinergic medications, there are many medications. One of the most widely used one is called, it's glycopyrrolate. It's marketed by the brand name Corposa, and it is indicated for treatment of sialorrhea in children with neurodevelopment disorders. However, from our clinicians, what we understood is, because this drug is administered orally, and there is a lot of systemic absorption of this drug, and because of that, there are so many anticholinergic adverse events, urinary and gastrointestinal retention, blurred vision, tachycardia. Even though it is a good drug that can give decent activity in terms of anti-sialagogue effect, its side effects are kind of like limiting its use. And the other commonly used medication is botulinum toxin you're injecting at the site. This is definitely very expensive, severe pain at the injection site, and it needs kind of like an invasive procedure, even though it's just an injection, but it needs someone who has to get into the glands and use ultrasound to find the glands and give it at the right spot. And another issue with botulinum toxin that we understood from our clinicians is um, sometimes when you paralyze, when you inject botulinum toxin, there are some, because of lack of precision in injecting, sometimes you kind of paralyze the muscles around the glands, and that kind of like reduces the ability for the patient to swallow. And then it's basically you're compounding the problem rather than treating it. And then surgical therapy, obviously you don't want to go to a invasive procedure of surgical therapy. It's expensive, and patients, it's painful for the patient, and post-operative maintenance is very difficult. So because of these drawbacks with the current treatment options, there is definitely an unmet medical need to use more effective therapeutic options. And due to these adverse events and also several other economic benefits and availability, what clinicians have been using all over the world are, they are using atropine eye drops that are, very easily available and very less expensive. And they are prescribing that to treat sialorrhea, where they will say, okay, put 2 drops under the mouth, under the tongue, or 3 drops under the tongue, so off-label. And this use has been increasing past few years, and they are widely using this as an off-label treatment. So we first initially looked into whether this approach of off-label use of atropine eye drops, is it any better when you compare with other routes of atropine? What's going on? So we did a systematic review and meta-analysis, the usual process. However, overall, we looked at 56 studies with around 2,300 patients, and we included that in systematic review, and we realized that our model showed that indeed sublingual administration of atropine eye drops is superior to other routes like oral and subcutaneous routes of administration. And it is, in fact, it is increasing the efficacy of the drug efficacy of the drug when used off-label. So what are the issues with using sublingual eye drops? The first thing we all know, off-label drug use in pediatrics is very common, but it has its own set of issues. Even though it's convenient, it's economically, you don't have to have a branded drug. You can just scale something from the adult formulation and you can use it. However, specific to the atropine eye drops, some of the issues are there are no optimal dosing recommendations. If you look at all these studies of how much drug has been administered, it varies anywhere between 2 drops to 20 drops. There is no, like, everybody are using a very empiric approach where they are just putting drops. Okay, it's working. All right, if it's not working, increase 2 more drops. So, and with a drug, anticholinergic drug like atropine, which can have systemic adverse effects, this is kind of not a nice gamble to take. Another adverse effect is these atropine eye drops, they are just aqueous solutions. So, if there is a rapid turnover of saliva, they are just washing out of the mucosal, oral mucosa. And another issue that these atropine eye drops have is, again, which is kind of related to low residence time, is it needs frequent dosing, which is a big burden for cerebral palsy patients, not only from a caregiver perspective, but from a parent's perspective as well. They have to give, if they have to give these drops every few hours, then it's kind of, it adds to that overall quality of life issue. And then another documented issue with atropine eye drops is high risk of medication errors. When you are giving eye drops to put under the tongue, there is so much that gets lost in translation. Many pharmacists in the audience can relate to, right? Like you give very specific directions, but still patient comes up with doing something completely opposite. You don't even think. And imagine if you have these many complications where the bottle looks different, looks like an eye drop. So there are a lot of medication errors. There were a lot of reports where patient accidentally swallowed the whole bottle, and there were like couple deaths because of medication errors. In fact, the TGA, which is the Australian FDA, put a warning, I think warning is the correct word, on off-label use of atropine, saying that they have to have extreme caution in prescribing atropine eye drops because of death of an adult patient. And there are several other reports in the United States as well, similar reports where there were atropine toxicity information. So because of all these issues, atropine eye drops use, even though it is getting, it is helpful, it's not an ideal way. So to address this, what we came up with is we were proposing a mucoadhesive atropine gel. So this is basically atropine formulated in a gel with a polymer that has capability to bind to the mucin of the mucosal layer and kind of like increase that residence time a little bit, with the hopes that this increase might reduce frequency, improve the local activities, keeps the drug more locally. And then a gel formulation, it can be, the advantage with this, the reason for choosing this is it can be easily adjusted based on the pediatric population, because, we have this whole spectrum of age with different weights. So we need a dosage form that can be easily adjusted. With gel it's easy to adjust. And a dedicated formulation for pediatric use is always good. It's one of the drawbacks of pediatric therapy in general. There are very few drugs that are approved for pediatric use, even though the number of drugs that are getting approved specifically for pediatrics is increasing, but still there is a large unmet need for getting approved formulation. So these are some of the things that we would like to address with the drawbacks of off-label use of atropine and other drugs used for sialorrhea. So our pathway to get this out in the market is we first did we developed the formulation, did some pre-formulation studies, made sure the gel is stable and there are all the FDA product requirements. We did that, and then we obtained an FDA approval. We submitted an FDA approval, and FDA recommended that we do a phase 1 study in adults before we move to pediatrics, to make sure that it is safe due to all this adverse systemic cardiac related adverse effects. And then we would like to do a phase 2 safety, PK, and efficacy study in pediatrics. And then ultimately our goal is to reach out to FDA and see if we can follow the 505(b)(2) pathway, which is basically a truncated version of approval process, where if your drug is already approved and you have a lot of toxicity data associated with it, you can truncate the number of studies needed for final approval. So this is kind of our pathway. And for today's talk, I'll be talking more about how we leveraged the phase 1 data, how we leveraged the PBPK modeling from phase 1 data to kind of inform our pediatric study design. So the phase 1 data, very straightforward. We did it at our University of Utah CTSI. Again, thanks to CTSI for providing these these avenues for us to do clinical research. We had a very nice facility where we could recruit participants, and we took 10 healthy subjects, both male and female, and we asked the participant to administer 1 gram of atropine gel. We divided the dose 50% into the buccal area and the 50% in the sublingual area, just to see, just to have a consistency in each patient. And then after 24 hours, we looked at systemic adverse effects. And during the time, we were looking at cardiac, we were monitoring cardiac activity by heart rate, blood pressure, and oxygen saturation, all these things. And then we analyzed the LCM, SMS, and did the PK analysis, pretty straightforward. And this is plasma concentration versus time data. There is a lot of variability, mainly because the gel application, how the patients were applying. And in general, atropine is a drug that has quite a bit of variability in PK. And then I just want to draw your attention to certain PK parameters. So we calculated the absorption rate constant using a 2-compartment model with PK analytics. And first thing I would like to draw your attention is the gel's overall bioavailability when you compare with the atropine eye drops. Even though we did not do a head-to-head comparison, this is from the published data. The atropine intravenous PK and the atropine eye drop data is from the published. The atropine gel is the data that we did in our phase 1 study. So overall, the dose-adjusted AUC, we have seen that overall bioavailability has reduced, kind of alluding to the fact that our strategy of kind of containing it in the oral cavity is valid. And then the absorption rate constant between atropine eye drops. So these are the drops that are given sublingually, and the gel that we gave, the absorption rate constant is significantly lower. Again, I would, with a caveat that these are not head-to-head comparisons. These are not done in the same study, but something to compare. So these are some of the observations from our phase 1. And then with respect to safety perspective, we looked at the heart rate change, and we did not see significant changes within the American Heart Association's definition of bradycardia and tachycardia. So we didn't see anything, any changes during the period after the administration. So we have this phase 1 adult PK data, and now we want to use this data to leverage and inform our further phase 2 studies in pediatrics. So the first study we would like to do in pediatrics is we want to do a safety and PK, kind of like repeat what we did in adults in pediatric patients with sialorrhea. And FDA was very concerned because number one, it's pediatric population, and number two, these are vulnerable children because they are neurodevelopmentally challenged, and they wanted us to be extra careful because of all the cardiac side effects. So we want to make sure when we go back, we will have some basis of dosing, and we would like to use this. So for this modeling exercise, we decided to use oral cavity compartmental absorption and transit model, OCAT PBPK model in GastroPlus, which is already a very nice model that was built in. So we were like, we will just use that model instead of building everything from scratch by ourselves. So this ocular cavity or OCAT PBPK model in GastroPlus is basically, as you can see, this is divided into several compartments, and buccal is your buccal area between the cheeks. Gingiva is under the tooth. Palate, the top part, tongue top, tongue bottom, floor. And the program, the model allows you to distribute the dose between these compartments. So in our case, because in our phase 1 data, we asked the healthy volunteers to kind of divide it between 50% between sublingual, under the tongue, and the buccal area. We kind of like divided it. And the blue arrows here represent the systemic circulation to and fro from the compartment, as you can see. And then the orange, bold orange lines represent the salivary flow. You know how the salivary flow is moving between these compartments, how it is flowing. And then the orange dashed line represents the swallowing pattern, from where, because we are constantly swallowing the saliva and swallowing pattern. This model is kind of like really well suited for our application, because there are a lot of things that we can change based on our patient's physiology, our patient population. So some of the parameters that this oral cavity PBPK model incorporates, I'm just skimming the surface here. I don't want to go much deep into the model, so please let me know if you have any questions about the specifics of the model. So some of the physiological properties that this model incorporates is blood flow to each of these compartments, surface area, thickness of the epithelial and lamina propria layers of these each compartments, and then saliva flow and swallowing, basal saliva volume, saliva production rates, how much the rate at which saliva is produced by these glands, which is very important for our application, because a lot of our patients that we have currently in our physical medicine and rehabilitation unit, a lot of them don't have salivary glands because they removed them. As I told you in the very beginning, surgical resection is one of the common things. So we will be able to incorporate those physiological changes in the model. But even though their major salivary glands are removed, their minor salivary glands are still working. So this is a very good thing for our modeling purposes. And they also incorporate swallowing pattern, normal versus holding. This is kind of not for us, but this is more for orally dispersible tablets or rapidly dissolving tablets, where you ask the patient to put the tablet on the tongue for a minute and then swallow. So for us, it's not a major thing. However, one of the reasons for salivation in cerebral palsy patients is not because their saliva are producing excessive fluid. Their saliva is operating at a normal as any other human being. Their swallowing ability, because of the paralysis of the muscles, goes down. So they are not swallowing as much as a healthy human can do. So we can incorporate those kind of, once we have good longitudinal data, we can incorporate those things. So this model allows for that. And the drug absorption in the oral cavity is basically based on equations related to instant partitioning between saliva and top layers of epithelium. And then tissue diffusion and systemic circulation uptake. This is another parameter that this oral cavity PBPK model is incorporated. So overall, for this pediatric PBPK oral cavity workflow, we first collected all the parameters related to atropine, drug-specific parameters. We used multiple approaches. We used literature sources. We used ADMIT predictor, which is kind of GastroPlus's in-house predicting QSPR predicting software that has ability to predict some of the drug-specific parameters and ADME data. And also, we gathered some parameters from our own phase 1 study. And then we used that, and we initially built an adult intravenous and oral PBPK model using GastroPlus with atropine, just to make sure the model is doing whatever it is supposed to do. And then we once the model looks good with intravenous and oral, we added the oral cavity compartment to it and evaluated the model's performance with our own phase 1 data that we did in our study. And then we extrapolated or scaled that adult pediatric model to adult model to pediatric oral cavity model, and then finally use that pediatric oral cavity PBPK model to predict some basic PK, basic PK in pediatric population. So these are the parameters that we used for oral cavity PBPK model input parameters. As I told you, we can give the model how much dose is given to which particular compartment. So in the phase 1 study, we did 50% buccal and 50% sublingual, so incorporated that. So I just quickly go through some of the model data. The intravenous data, the model looks good. The observed versus the black line represents the simulated data, and the red dots represent the observed data. The observed data we obtained from literature, from different studies. And then we looked at the adult atropine oral data. The model is a little under predicting, but when we also, in addition to visual checks, we also did the AFV and AAFV values, and also looked at how much deviation is between the PK parameters like Cmax and AUC, and they're all within the range. And then this is the oral cavity PBPK adult model predictions using our phase 1 data. And the model is predicting very well in terms of when you compare with observed data. Again, the red lines are observed data. And once we are convinced that this is looking good, we use this model to oral cavity pediatric PBPK model simulations. And I'll just want to discuss certain aspects that we incorporated in these simulations to give more clarity. So the scaling from adult to pediatric in GastroPlus is based on a technology, or I don't know what is the correct word to say, but their own module called PAIR physiology, PEAR, which relates to population estimates for age-related physiology. So they have inbuilt ontogeny equations and inbuilt physiological changes based on age that will incorporate the age-related changes from adults to pediatrics. So we use that. And then we created virtual population from 1 year to 18 years. So as I told you earlier, initially we would like to do a safety and PK study in pediatrics. So we just want to see, so what is our population that we have? So in our PM&R, usually the population of children we have is around 1 to 18 years, and with sialorrhea patients. So we just wanted to kind of broadly, look into how the atropine PK looks. And once we have nice finely tuned model, we will eventually do different age group wise predictions. But initially, for this initial modeling exercise predicting, we lumped all these pediatrics into one group, long group. And another thing that we looked into is, what are our targets? So again, because of off-label use, there is not much data available, and we don't have any internal data related to toxicity or efficacy, because that hasn't been studied that much. So we are relying only on the data that has been published so far. So the target efficacy concentration, there was a study where they gave atropine eye drops sublingually, and they concluded that 1.46 nanogram per milliliter is kind of a good concentration that showed reduction, almost 50% reduction in salivary flow. So we kind of chose that as our efficacy concentration. And target toxicity concentration, we obtained this from a study published in JAMA Pediatrics, where they looked at children who were accidentally overdosed with atropine using those injectors. And the children, they collected samples from children who showed very high degree of atropinization. That's kind of like giving all the adverse effects, and they evaluated the drug concentrations. And in that, they reported that 61 nanogram per milliliter is kind of like a toxic concentration. So initially, and then we did a dose range of 0.1 to 8 milligram per day in our simulations. And for the initial modeling, our major goal was to see between this 0.1 to 8 milligram how the toxicity is looking, and how it is looking. So we did the simulations, and as you can see here, is the blue is the efficacy target and red is the safety target. And any dose of 1 milligram per day, over 1 milligram per day, is kind of over that efficacy target. And then up to 8 milligrams per day, still it is lower than the safety target. So kind of giving us a range of, obviously we won't go up to 8 milligram per day. We are looking somewhere around 1 to 2 milligrams per day. That is normal upper limit of these drops that were given usually in off-label use. So that's kind of where we want to hover around. But just this gives us an idea of kind of, letting FDA know that, this is what we are looking at. And obviously, these are all based on clinical studies. So we need to develop our own data down the road. So that's kind of like the goal of where we are at right now. And once we do the safety and PK study in pediatric patients with sialorrhea, we would go back and verify our oral cavity pediatric PBPK model and kind of like further refine and go through the developmental pathway. So quick conclusions, mucoadhesive gel formulation, which is dedicated, may be a better option than just putting some eye drops in these patients. And the adult oral cavity model was successfully developed and verified with phase 1 clinical data. And the pediatric oral cavity model was scaled from adult using the pair physiology, which is gastro plus internal. And the simulation showed that for doses up to 8 milligram per day, atropine levels did not reach to a toxic threshold. And a minimum dose of 1 milligram per day is kind of required to reach efficacy threshold. Again, all these things have to be verified. This is our initial estimation. So future directions. So some of the parameters that GastroPlus, we relied on GastroPlus were the diffusivity parameters. That's the diffusion of the drug through the layers. So, and we used the parameters that were predicted by the software, but we would like to check how close it is to reality. So we are currently performing some ex vivo studies in porcine, sublingual, and buccal mucosa, where we just put the drug in the top donor compartment and collect and see. We just want to make sure, kind of another way to validate the diffusivity equations that GastroPlus already have in place. They did a robust job. They took 9 drugs and did these ex vivo studies and used the data from those 9 drugs and incorporated the equation. They validated pretty well, but again, it doesn't hurt to have another step, especially if it is a ex vivo study. And then refine the oral cavity PBPK with new parameters if there is a difference. And then perform a phase 2A safety and PK study. We're getting ready for this. We already have the IND. We just need to update it with a new clinical study protocol. And then verify the pediatric model, and then go to FDA and see what will be the pathway moving forward for a 505(b)(2) application. I would like to thank Primary Children's Hospital Foundation, Salt Lake City, Utah, for providing funding for this study, our Division of Complex Care who are very helpful in providing the clinical knowledge, and Division of Clinical Pharmacology clinicians who helped with phase 1 study, and then College of Pharmacy for providing formulation. And then huge thanks to Simulations Plus for providing academic licenses of Peak Analytics and Gastro Plus. It has been very helpful. They've been very generous in providing licenses, and be happy to take any questions if we have time.
Thank you so much.
Okay, this is really, really elegant work. So I had a couple of clarifying questions, mainly on the PBPK modeling. When you use the pair scaling, was that to scale the anticipated blood flows and surface areas from the adult model to the various pediatric scales? Okay, so it was using
Yes,
what is it,
yes,
the PEAR and the PEAR algorithm, whatever.
Yeah, so it's all based on, depending on the drug, it's based on, if it is CYP mediated metabolism, then it has all the equations for each CYP based, it is all the same equations. And then with respect to specifically to oral cavity compartment, it's more physiological, like you said, blood flows, tissue thickness,
Okay.
tissue keratinization is also included, because each compartment has different keratinization, and that changes with pediatric age. So those were also incorporated in that pair physiology.
Wonderful, that's terrific. And are any of these models published, or are they available as
Yes.
modules? They are, okay.
Yes, yeah. So GastroPlus published almost 3 to 4 papers, and they provide complete details of the model, including the equations involved, and they have examples of several drugs, but not in terms of topical administration. They are more like ODT, rapidly dissolving tablets, where you put the tablet on the tongue, it dissolves, and you swallow.
Okay.
But they have 4 to 5 publications, not any in pediatric ocular model, but
So there's an adult oral cavity model that is published, but parameterized with respect to the drug passage based on orally disintegrating tablets.
yes.
Okay.
Yes,
Great.
several of them.
Wonderful. Thank you.
Propranolol, zolpidem.
Terrific.
Yeah, Dr.
I think I have missed this. So what are the elimination pathways for atropine?
Elimination pathways? Yeah, I did not discuss it, so that was a good question. So it is eliminated predominantly by enzymatic hydrolysis by liver, and then 50% is excreted unchanged in urine. So those are the two, we divided the clearance into these 2 pathways in the model.
And what did you assume for translation to children? Like how, like allometric scaling of each
Yes.
pathway based on weight?
So the pair physiology, I think it has some kind of allometric scaling based equation built in for scaling from adults to pediatrics.
Okay, so kind of like a generic equation.
Yes.
Because, okay.
Yeah.
And for the renal part?
Same thing. So it's already inbuilt in pair physiology. I don't exactly know what equation they used, but we were relying on their pair physiology algorithm.
Thank you.
But they have an equation, especially with respect to glomerular filtration rate, and which is, I think, just the generic equation, nothing specific to this drug.
Kash, great work. 2 questions. With respect to delivery of drugs via the kind of mucoadhesive or buccal adhesive routes, we don't often think about that for chronic long-term administration. So I was curious, 2 questions. One, does the model address accumulation in the buccal tissue itself? And the second is, can you talk about the ulcerogenic potential of long-term use of this compound?
So the residence time, first thing I would like to clarify is, even though it is mucoadhesive, it's not like a glue that coats for a long time. The interactions are still very temporary, to be honest with you. For example, according to the company that manufactures these mucoadhesive polymers, the current rate of contact between mucin and the polymer is governed by the amount of turnover. So if this mucus, for example, in our case, if saliva washes this polymer off within few minutes, it's gone. So because of that, it's not staying there for a long time. That's a drawback. Even though we are saying it is mucoadhesive, it's not really, we are not getting, if that's one thing I did not highlight, is we didn't see a huge change in half-life in our data between our formulation and the drug that was given sublingually. We didn't see huge change. So it's not staying there for a long time. And because of that, we don't see any major issues with ulcerogenic potential. It will be a little better than atropine eye drops, but it won't be, it's basically kind of like, better than off-label. We will have a dedicated formulation. Does that answer your question?
Hi, nice work, Kash. Two questions. So you said based on your simulations, you found 1 milligram per day to meet the efficacy target. So how was the 1.5 nanogram per ml was derived based on adult studies in sialorrhea?
No, it was pediatric in cerebral palsy patients. So
Uh,
it was a prospective study that was performed that compared sublingual atropine eye drops with intramuscular atropine. They took like 6 patients each, and then they did PK and efficacy. They also measured salivary flow
Mm.
and kind of correlated that. So the data, the efficacy target is from that publication.
I see. So in your case, the gel, when you said it's per day, do you anticipate looking into like multiple administration, or it is going to be a single administration?
That is something we are still deciding on. We are working with our statisticians to come up with a better study design, but we are looking at a study design where we do single administration and probably divide the dose into 2 administrations, one in the morning, one in the evening. So that's why when we are doing simulations, we did it as a per day. But once we validate the model, we will do more specific, individualized simulations.
Yeah.
as
So
well.
related to that, so my question, you said the approval pathway is 505(b)(2).
Uh-huh.
So you require safety and PK studies in children, and also you said efficacy studies. So do you think FDA would be open to MIDD approaches rather than doing an efficacy study? You do a PK matching study. Have you thought
That's our
about that?
hope and dream. So that's what we are hedging our bets on, because in academia, we are not industry. We don't have millions and millions to take things further. So we are hopefully, they can allow some of the MIDD approaches to support our final study. So
So we're taking our last question.
Yeah, so I just had a general question for the use of anticholinergics or atropine in this population. So I
Mhm.
know that some populations are more at risk for the neurologic side effects of anticholinergics. Specifically, I'm thinking of populations greater than 65 years old,
Uh-huh.
which is why it's on Beers criteria. And seeing that this population has neurodevelopmental challenges, I wanted to know if that could pose an issue or pose increased risk to these side effects in this population.
Definitely. That's one of the reasons why we want to come up with a dosage form that is more locally targeted, that will reduce systemic absorption. That's precisely the reason we want to, because when we are targeting locally, we can reduce the overall dose. So like right now, they are using up to 4 milligrams a day in some kids. They are just putting as much drops, depending of. So our goal is by containing this in the oral cavity, we can reduce the dose, and it will overcome all the systemic adverse effects, because those adverse effects are all systemic, because the drug is getting into systemic circulation. But that is something we have to study. We have all those in our safety and PK. We have all those parameters as our endpoints in our upcoming safety study in pediatrics, but we have to study. Yeah, that's a good point.
Yeah, with that, we thank Dr. Kash. And we have a break in 10:20. Unfortunately, it's a short time, but due to the schedules, we have to come back 10:20. Thank you.